Welcome to Neuro Frontiers, a series in which Practical Neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. In this episode, Paul Kruszka, MD, Chief Medical Officer at GeneDx in Stamford, Connecticut, provides an overview of advanced genomic testing, emphasizing guidelines physicians should follow when ordering genetic tests, as well as the utility of these tests for diagnosis and treatment decisions.
Hello, I'm Greg Jensen, editor with Practical Neurology, and today I have the privilege of speaking with Dr. Paul Kruszka. Dr. Kruszka, please tell us about the work GeneDx has been doing and your role within the company.
I'm a clinician by training. I'm a clinical geneticist, and I've retired from the NIH before coming over to the GeneDx. I was a physician scientist there. My role at GeneDx, as I mentioned, I'm the chief medical officer. I wear a number of different hats at GeneDx. One is a clinical advisory to the company. Another is I organize and run medical affairs. We do a lot of education. I organize and lead a number of exciting research projects. One of my favorite projects is the Guardian Project, and this is where we're doing newborn screening with whole genome sequencing, looking at over 400 genes in newborns. The study takes place in New York City at Columbia University in the Presbyterian Hospital System. And a lot of the genes we're looking at are neurodevelopmental disorder genes and seizure genes. And a lot of what we do is to decrease what we call the diagnostic odyssey, and that's when symptoms start to when you have a diagnosis.
Please provide an overview of the genetic testing landscape and the categories of tests currently available. What are the key developments in genetic testing over the last 5 years?
This is an exciting topic, how genetic testing has changed over the last 5 years, how it's changed really over the last 50 years, and how it will continue to change. It's a moving target. Around 2010, gene discovery paper was published. It was a syndrome called Miller syndrome, published by Mike Bamshed at Seattle Children's. And this really started the exome journey. Exome is a test that tests all your base pairs, but it only looks at the protein coding regions of the genome. It does what a microarray does and more. So it can find large chunks of DNA missing, or it can find single base pair changes. And again, this is only in the protein coding region, which is about 1.5% of our genome. And this has been the mainstay. The payers are paying for it now. 28 out of 50 states, the Medicaid programs pay for this. The diagnostic yield is decent, 25%. Private payers are paying for it. We're seeing a steep spike in neurologists, especially pediatric neurologists, that are ordering the whole exome sequencing test. So that's where we are today. So the next step is really the genome, and we're doing that in inpatient. And neurologists certainly are rounding in these places. In the neonatal intensive care unit, you have infants who are having seizures, hypotonia, or a host of other neurological disorders. Now, the whole genome sequencing is similar to the exome sequencing. The technology is very similar, except it does 100% of the genome, or almost 100%. So exome does 1.5% of the genome, the coding regions. And then we're going to go to a different technology probably in 5 years from now. That's my prediction. And that's called long read sequencing, or LRS. And there's a few companies out there that have developed this technology.
Thanks so much for that overview. And next, I'd like to ask you about the advantages and disadvantages of advanced genomic testing versus other categories of genetic testing, such as genetic panel tests.
5, 6, 7 years ago, panels were very popular. And panels are a number of genes that we would test all at once by various technologies, whether it was Sanger sequencing or the next generation sequencing, which is exome and genome sequencing. And this is a discrete number of genes. We did this for years because insurance companies paid for it, because it was cheaper, because we're generating less data. But sequencing has become less expensive, and the number of answers you get are much higher with exome and genome. We moved away from panels. Unfortunately, the professional guidelines had moved away from panels too and recommend exome and genome sequencing as a first line for a lot of the neurological conditions such as developmental delay, intellectual disability, and unexplained epilepsy. We have presented some data at previous conferences in the last 12 months. One of the conferences was Child Neurology Society, and we looked at 22,000 cases of epilepsy. These are mainly children, but some adults. And their medical provider took a blood sample, sent it to us, or a swab. We sequenced their DNA, so 22,000 people. And what we found was our diagnostic yield overall was 24% with exome. But the most important part was 57% of the genes that we found answers were not on panels. And we looked at all panels, not just the GeneDx panels. We looked at all commercial companies, combined all those genes. So the diagnostic yield is much higher. Also, if you look in the medical literature, there was a meta-analysis done in 2021 that led to the guidelines that are endorsed by the American Epilepsy Society. And they looked at 39,000 people. What they found was the diagnostic yield for genome sequencing was 48%, exome sequencing 24%. The panels were lower, less than 20%, and microarray was 9%. As the technology advances, there's more answers for patients. And now with less expensive cost, it's just better to go to a exome or a genome test for this. Now, I want to say one caveat about all the statistics I gave you. Most of those individuals had a prior genetic test. The yield would actually be higher than what we found, 24%. We're getting people that have already had a panel and then had an exome. Really, it doesn't make sense to do a panel, then an exome. Why not just cut to the chase and do an exome?
You hinted at the changing nature of guidelines. For clinicians, what are the guidelines or considerations that they should follow when considering ordering whole exome and genome sequencing? And as a follow-up to that, who are the candidates for these tests?
There's a number of guidelines out there, and the medical literature is filled with a lot of evidence that the guidelines are based on. I'll point out two guidelines. In 2021, the American College of Medical Genetics put out some guidelines on exome and genome testing as a first-tier test. The indications for this was developmental delay, which is seen by neurologists, intellectual disability, and congenital anomaly. So there's one set of guidelines. Then there was another set of guidelines that was put out in 2022 and endorsed by the American Epilepsy Society. And this focused on epilepsy. Both of these guidelines were based on meta-analysis. The second guidelines that I spoke of is the epilepsy guidelines. And that also says genome sequencing or exome sequencing as a first tier test and preferred over panels. As time goes on, we'll see more guidelines. I am on the guideline committee with the American College of Medical Genetics, so I know there will be more guidelines coming out as we mount evidence. And that guidelines take years to make. So just because there's not guidelines, that doesn't mean we shouldn't be doing genetic testing for other indications. The next step past guidelines is payers. And what we're seeing is the payers are very favorable and want to do the right thing for their cohorts. And they're endorsing evidence-based guidelines. A lot of conditions are being supported by the payers.
And moving past the guidelines, let's say that the test is ordered, the results come in. How is the genomic data utilized for clinical diagnoses? And then how is it used to direct treatment?
If you talk to a clinician like myself, what is actionable? There's two answers to this. The most important person is the affected person and their family. They want to know, why did this happen to me? So they know they have an answer. And they stop looking for an answer. Maybe they're not going to go to a tertiary care or university medical center or cross state lines or get unnecessary testing, because now they know what is causing their condition. So that's very important for them. There's other issues too. When you talk to parents, sometimes there's guilt with their child being affected with a neurological condition. Was I exposed to something? Did I not get enough rest? Did I cause this for my child? The third thing I want to touch on with the families is once they get a diagnosis, they find a community. Often The physician, the provider will introduce them to a patient advocacy group. They'll go on Google and find their group, maybe Facebook, social media. And when they find their community, this opens up a whole new world. They have other people that are going through the same thing. The information exchange is great. And a lot of times with the rare disease ecosystem, when they find their community, they start raising money, they start developing companies, they start funding research. So there's a lot that happens with the patient. And I feel like we don't talk about that enough. Now, let's go over to the provider side. Once you know the genetic diagnosis, you change the therapy. Maybe you change the medications. And sometimes it doesn't have to be as sophisticated as a gene therapy. Sometimes it's just a diet-related intervention.
Lastly, I'd like to discuss issues surrounding access. What are some barriers to patient and provider access to advanced genomic testing? And what steps need to be taken to increase patient and provider access to these tests?
So I'm going to start on a very positive note, and that things are changing dramatically. Just since I've started at GeneDx, I've only been here 3 years, and the payers are coming around. They're paying for exome. They're paying for genome for a lot of neurological disorders. So that's wonderful. We still have a ways to go, but there's been remarkable progress. The guidelines have all come out since I've been at GeneDx, the 2 guidelines from ACMG and the American Epilepsy Society endorsed guidelines. I only want to talk about one barrier. If you think about traditionally how genetic testing has worked in the United States, genetic counselors and clinical geneticists have ordered these tests. Well, we have a problem. There's not that many clinical geneticists. I was on faculty at NIH where we had a training program, and I can tell you nationally, we were only training, and to this day, only train about 25 geneticists a year. There's just not enough of them. Some of the waiting times to get in to see clinical geneticists can be 1 to 2 years. Some states during certain periods of time have not had a clinical geneticist. And so we need pediatric neurologists and adult neurologists to take the baton, because so much of their practice is genetic. If you go through these practices and you start naming clinical presentations, epilepsy, neurodevelopmental delay, autism, hypotonia, adult ataxias, hereditary ataxias, neuromuscular disorders, many of them have a genetic basis. The number one barrier I see is getting neurologists to get on board with genetic testing, to learn about it. And that's happening. There's a larger and larger percentage of people that are ordering exome and genome. The barrier that I want to focus on is the provider barrier and decreasing that diagnostic odyssey. The average patient with a genetic condition waits 5 to 7 years to get a diagnosis. There's no reason for that. We're entering a new era, and it's really exciting because we are seeing pediatric neurologists order more and more of the test. Now, there's a bump in the road. Maybe they don't understand a certain genetic result. We have over 100 genetic counselors that are often helping with results, with pre-test counseling. So there's a lot of help out there, but waiting 2 years or a year to see a clinical geneticist is the barrier, and that negatively impacts patients and families.
Dr. Kruszka, thanks so much for speaking with us today. Appreciate your time and expertise.
I really appreciate you having me on.
Thanks to Dr. Kruszka for sharing his knowledge with our listeners in this episode of Neuro Frontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.